of all, can you all make sure your phones are on silent? You're not allowed to turn them off because you may, if you wish to, submit questions to us. I'm in charge of the iPad at our end, so don't rely on the fact that I'll actually get your questions. Please send a few in because we're going to have a bit of time in this session. So thanks to Paul Jones for asking me to give this, chair this session on MDTs. A really interesting area. For those of you who don't know me, I'm a consultant urological surgeon at St George's in Tooting, and I'm predominantly a benign man. I spend most of my time in the upper tract, but I do a benign MDT, and I go to the upper tract MDT with my uro-oncological colleagues. The session we're going to do this morning is 45 minutes. Each speaker's got about 12 minutes each, and we're going to cover, I think, the most interesting and challenging areas of MDT practice. We're going to ask Hash, first of all, who's all very well known to you, to give the NHS England perspective. Hash, at the moment, is the chair of the Clinical Effectiveness Group on Prostate Cancer at NHS England. And really what I want from Hash is to give us a feeling of what the legislative statutory framework around MDTs is. In other words, what have we got to do? And then I've asked Joe Cresswell, as chair of the section of oncology, to give us a feel for actually what's going on at the coalface. What are you guys actually doing as far as MDTs are concerned? How effective, how difficult, what are the impact on your job plans, etc. And then I've asked Billy Dunsmuir to do the soothsayer bit, which is to try and predict what the future might look like. And knowing Billy, it'll come from a slightly left field point of view. He has more degrees outside of medicine than actually within medicine. Not many of us can say that. The great phrase is, there's no I's in team, but there are 5 in individual brilliance. As surgeons, we have very big egos, but that's one of the things I want to tease out a little today about how our behavior as surgeons impact on the team themselves. Hopefully this group of players, with perhaps 1 or 2 superstars, will go a long way, but they are a really good example of team working. Okay, Hash, if I could ask you to come up and start.
Thank you very much, Ken and BAUS, for inviting me to speak on behalf of NHS England. So my remit is somewhat limited according to national policy as well, but I'll try and give some of my own thoughts. NHS England recently constituted the clinical expert group in prostate cancer, myself as chair and Freddie Hamdy is vice chair. We had our first meeting last week of a number of experts from a number of disciplines, and one of our packages of work will be to advise NHS England and also seek your advice and help and support in how we can change the way we work with multidisciplinary teams, particularly in prostate cancer. So there's no doubt that there has been a significant growth in the number of MDT discussions over the years and the cost in delivering this, but there has been very little in the way of increases in manpower. And the blue line represents the increase in MDT discussions, and the other lines represent a very stagnant pool of multidisciplinary teams to deliver this. And so something really does need to change. Cancer Research UK carried out an extensive report on this and did a number of surveys of physicians, and they quote this particular quote within their report: "Far too many routine decisions are made at MDT. We're intelligent, highly trained professionals, but now have been trained to be unable to make a decision." And I think a lot of us can sympathize with that comment. But nonetheless, multidisciplinary team working is the gold standard for patient management, and none of us should move away from the fact that the overarching principle of MDT working is here to stay, and that is still national policy. The report from Cancer Research UK did also show that we're probably not doing a great job in discussing some of the more complex cases. On average, we're spending very little time discussing each individual case. So this survey showed from about 3,300 responses, and primarily urology MDTs, interestingly enough, were dominant in this survey. And it showed that 48% of patients are discussed for less than 2 minutes and 2/3 for less than 3 minutes. And an increasing recognition that the mandatory attendance is probably something we also need to look at again, because the number of people contributing to most discussions is not the entire MDT. And I'm sure, again, many of us will recognize the fact that we have 15 to 20 people present at most MDTs, but very few contributing to every single discussion. So we need to look at streamlining job plans and also streamlining our guidance around compulsory attendance for every single physician and allied health professional. Clearly, the demand that we're going to see on MDTs is going to rise, and it's going to almost double in the next 10 to 15 years. And particularly around prostate cancer, despite the lack of an NHS screening program, due to increased awareness, due to increased PSA testing, due to increased reassurance by GPs and patients around the new pathway with MRI, active surveillance, we're going to see a significant growth in number of men referred with PSA elevations and who require testing. And I think all of us have seen that already, probably over the last 6 months. Partly it's my fault, and partly it is this increased awareness that we're seeing. Certainly over the last 6 months, we've seen 100% growth at Imperial in number of men referred in with an elevated PSA. And that fits with NHS England's strategy, national policy for early diagnosis. So we want to diagnose those cancers that do need to be treated earlier. And that strategy needs to, that second arrow should be over the bladder cancer bar chart. But nonetheless, the pattern, apart from testis, is that there will be increased numbers going through MDTs. So there is a national recognition that we need to streamline the MDT process. And it's highlighted by the Independent Cancer Task Force recommendation, which stipulated in Recommendation 38 that NHS England should encourage providers to streamline MDT meetings, processes such that specialist time is focused on those cancer cases that don't follow well-established clinical pathways, with other patients being discussed more briefly. And as you'll see, national implementation includes also possibly not discussing some cases at all. So the task force recommended, and NHS England have taken this as a significant recommendation to implement, is to refocus team meetings on patients with complex needs. Specialist attention should be devoted to those patients who need it most, and we need to start to streamline how we deliver treatment approaches. I've thrown the last bit of this slide in because it's something that we as urological surgeons need to really input into, because this recommendation and this particular stipulation, I don't think many of us would necessarily agree with. Because they've said that we don't necessarily need more surgeons doing complex surgery, and more surgeons should be doing diagnostic work and more generalist work. And whilst that might be true to a certain extent, I know most surgeons who do complex surgery, if they were doing this day in, day out, there is an issue around burnout, there is an issue around individuals not getting the help in doing complex surgery, and therefore I think there is a need to look at this particular recommendation. And interestingly enough, this is not NHS England policy at the moment. So this has not got into the implementation policy document. But it is something that we as an organization, need to be aware of, that if we don't input into these kind of reports, then our own thoughts, our own thinking on complex cancer surgery may not be taken into account. And certainly, I think all of us know that there is certainly no oversupply of specialist registrars in urology. We are significantly short. Cancer Research UK also looked at whether specialists would be receptive to streamlining MDT processes across different tumor types. And they looked at skin and head and neck in particular. And as you can see, there are differences between tumor types. And I think the same will be found if we asked a group of prostate specialists versus a group of bladder or upper tract TCC specialists. Most bladder cancers probably should be discussed. Most prostate cancer cases probably don't need to be discussed to the length that they should. So how are we going to try and take this strategy forward nationally? NHS England do want to implement Recommendation 38, and they will be issuing guidance to cancer alliances across the UK to streamline MDTs, to increase time available for patients with complex cases, and have agreed pathways. And the low-hanging fruit, if you like, is going to be prostate. And prostate cancer has been prioritized as the cancer that NHS England will initially deal with, as well as colorectal and breast going forward in terms of this particular recommendation. But they will want to audit, and there will be probably increase resource required to audit and data capture the decisions that we're making. And this is a detailed slide, but it's worth concentrating on. They're going to pilot this implementation of streamlining MDTs in a number of cancer alliances in summer 2018. And at the moment, prior to the pilot, this is not official NHS England policy. They will be learning from these pilots in order to determine the best way forward nationally. And so we're going to ask cancer alliances to agree on locally agreed pathways. And again, as I said, it will be predominantly prostate. It does not remove any patients from oversight of the MDT. The ultimate responsibility will still be towards an MDT discussion. So all patients should still be listed, but they may undergo a pre-triage phase. And so anybody who's a chair of an MDT, like I was a year ago at UCLH, there is going to be an increased amount of time required for chairs to pre-triage or triage the MDT list to determine which ones could go for the streamlined approach. And although there is a recognition that not one size fits all, there are some stages of disease, some risk of disease, renal tumors, small renal masses, localized intermediate risk and low risk prostate cancer, for instance, where there are established guidelines, established approaches which could be adopted without requiring a detailed MDT discussion. And there will still be a requirement for comprehensive data collection. Clearly, if we're going to start to triage patients before the MDT discussion, there will need to be a significant amount of data collection and minimum data sets before the MDTs start themselves. And that may be problematic. We may be shifting the burden to individuals before the MDT. So we do need to look at this in pilots to see what occurs on the coalface. And importantly, from my perspective and everyone's perspective, is that we still need to make sure that clinical trials are considered for every suitable and eligible patient. And this yet hasn't got into the implementation guidelines, but I think will start to be increasingly recognized as something that we do need to look at. So national requirements for minimum attendance, having 15 to 20 individuals attend every single MDT, is not something that probably going forward is required. The NHS England team wanted me to specifically mention this. There are going to be timed pathways being implemented, and this should help with MDT working, because you will start to get the minimum data set required, because the diagnostic pathway will mandate that. The prostate pathway has been launched, and there's an implementation guideline for implementing a new streamlined 14 to 28-day pathway to deliver predominantly pre-biopsy MRI. And all cancer alliances have been asked to implement this pathway, at least the 28-day, and increasingly towards 14-day to diagnosis. So in conclusion, there's a national recognition that MDT process needs to be streamlined to be fit for the modern era. National guidance on overall parameters for agreed pathways for non-complex cases will be issued, but there will still be locally agreed streamlined pathways by cancer alliances. So you will still be able to input according to local expertise and practice. And prostate cancer will be considered as the priority area, predominantly because there's going to be the greatest growth in that particular cancer. Thank you very much.
Thanks very much, Ash. Sorry, could I have the microphone on? Yes, on, thanks. And Joe, if I can ask you to pop up. I hope you can see Jo. She's slightly worried about a colour clash at the moment, so she asked if the whole of the background could be changed to red, but we couldn't achieve that in time.
Thanks, Ken. Good morning, and thanks for the opportunity to contribute. If you do lose sight of me, I'm over here, okay? It's usually because the lectern's too tall. Today it's because of the dress sense. So my remit is to talk about the reality at the coalface. And the first thing to say is news from the north, there is no coalface, it's gone. And I think a similar transformation has taken place in the NHS since the start of the millennium, when I first got involved in MDTs. Coalface has now been replaced by shiny new wind turbines, and of course in our MDTs we're now dealing with increasingly sophisticated and shiny new treatments, and we're also dealing with a much greater complexity in our patients, things that we're considering now to do for patients in their 80s with multiple comorbidities that we would never have dreamed of doing, 20 years ago. And this makes it a little difficult. And also, the resource background that we're working in means that whilst the MDT has many good things, not everybody is happy with the amount of resource and time they're having to put into MDTs. And really, I think the grassroots opinion would be that it is time for change. So I'm going to try and give you an idea about the good and bad things that are happening in MDTs across the UK. This is very much non-evidence-based. This is based on a couple of years of talking to people informally and formally about MDT processes and cancer treatments in the UK. And there are many of you in the audience that either wittingly or unwittingly will have given me material for my talk. Some of you I've asked recently, and you've openly shared your thoughts, and for that I'm grateful. Others of you may just recognise one or two phrases you've used over the years when in my company. So let's start with the positive. There's no doubt about it that the MDT can have a very positive impact on our working practices and our cancer treatments. We work in an increasingly frenetic environment. We don't have an opportunity to talk to colleagues very often, even within our own specialty, never mind within other disciplines. And the MDT is perhaps one of the only times of the working week where we actually have a conversation about what we're doing and how we're treating our patients. I felt that this was particularly important at the outset of my consultant career, and I know others feel similarly. It's a time when you can have some informal mentorship. You can present your cases at the MDT, you can sense check your decisions and get ideas from senior colleagues. But I'd also turn that on its head in that I think we all benefit as established consultants in having newer members of the MDT join who are developing up-to-date practices and challenging some of our entrenched rote learning ideas. And I think so both established consultants and newer consultants can benefit from this. There is peer support for decisions, and I think that is comforting. at a time when our decision-making is under great scrutiny and will often be second-guessed with hindsight later down the line. And there is a certain comfort in that you've discussed it with a group of sensible people who know something about cancer. I think maybe it's also comforting, rightly or wrongly, to the patients that a group of experts, so-called experts sometimes, have discussed their case and have given a consensus opinion. Now, I put up the panorama slide there because we all know that this doesn't eliminate the risk of having rogue decision-making and patients not being informed properly of their choices. But it is one of the structures in place where bad practice, poor practice may be recognised or called out. And particularly if it's systematic demonstration that cases are not being discussed within the MDT. So some examples of good practice, and I'm not going to go through them all. Certainly, chairmanship is absolutely crucial to this, and that's what can make an MDT work or not work. I think we all value the high-quality radiology and pathology review that we need. And if used properly, you can get a rapid dissemination of outcomes and speed the pathway up. Now, Hash has already discussed a little bit about some of the changes ahead, and it's interesting that a lot of people I've talked to who've mentioned good practice are describing some of the changes that NHS England has picked up on. For example, a lot of MDTs now already use a protocolized approach for those cancers where it's obvious what the guidance says and it's fairly obvious what the pathway is going to be. So, for example, a small low-grade bladder tumour, you don't need to discuss that in detail. You're going to do a check cystoscopy at 3 months. We've heard about prostate cancer lending itself to this. And this really can reduce unnecessary discussion. And actually, it's happening already all over the UK, but not everywhere. It can accelerate the pathway when used properly. It can also delay the pathway, and I'll come on to that in a moment. However, if you have outcomes that are contemporaneously recorded, we can all see the outcome on the screen, and that is transmitted on that day to all concerned, including the GP, that good communication can facilitate patient management. Additionally, if you're in that room with the specialists involved, you don't then need to see the patient make the referral right to the oncologist. You should all be able to there and then say, yes, this patient should be recommended a choice of these active treatments, consider this clinical trial, and they're going to see that urology specialist and that oncology specialist within the week. Make the appointments immediately from the MDT. This is happening, and this is good practice. But let's get on to the more interesting stuff, the pet hates. And I'm sure all of you in the room probably have more to say about these than you do about the good things. You know about the costs, the manpower and so on. We've already heard about that. But let's hear about some of the bugbears that I've heard a lot about. And I suspect some of these might resonate with you. Massive, massive numbers of cases. And I think urology is possibly the worst culprit in terms of cancer MDTs of any. And talking to people around the UK, the average MDT is discussing 50 upwards numbers of patients, and I've heard up to 120 and over being discussed in a single MDT. We know that equates to about 2 minutes or less each. Rushed decisions, probably completely pointless. With another adverse effect from it, the other consequence of this is, with the best will in the world, everybody is exhausted, everybody is fatigued. By the time you get to the MDT, half the group have left the room, the other half are on their phones, and whatever's left are asleep. You can usually be the only person actually discussing the case by the end of the MDT. Not only that, if you arrange your MDT in the same structure every week, systematically you disadvantage certain groups. So if you always discuss your prostate cancer cases first, then your kidney cancer, then your bladder cancer, your complex bladder cancer patients may be the ones that are in a rush discussion as the screen's been switched off and everybody's leaving through the front door. And that is a real problem, I think, and needs to be addressed. Other examples of poor practice. Some colleagues, and this is particularly true for oncologists, perhaps less for surgeons, but it does happen, can have multiple MDTs in their work plan. You can end up discussing cases way more than you're treating them. And this has to, I think, change as well. It's not the same everywhere, but some colleagues who are in more than one specialist site-specific MDT and a local MDT and which is good practice, also discuss their private cases in an MDT, this is what their timetable starts looking like. The loudest voice can overrule. Now, often that is the surgeon in the room, but it is a problem because the point of the meeting is to get other options and other ideas discussed. And we all know that our clinical nurse specialists will probably not be interrupting the loudest voice to give them another opinion. And I think this can happen, and it's another example where good chairmanship is essential. And remember, that loudest voice, if you disagree with it, your name is still on there as a member of the team that recorded that as a team decision. MDT tennis. This is my personal pet hate. This is where you kick the can down the road from one MDT to the next. So there's a little bit of information not present or something's not quite there. Defer to next week. And you can even see a patient where it's been happening week after week, 2 to 3 weeks, defer to next week. Is it site-specific? Is it a urological cancer? Could it be a colorectal? Could it be a gynae? Let's refer it to another MDT. Let's refer it to another MDT. Nobody takes ownership. Poor patient still waiting to hear what's wrong with them and what the treatment is. And this idea that no decision is made until you've got an MDT outcome. Which leads me nicely into this culture of laziness that I think we can all be guilty of. That we as clinicians can stop owning our patients, stop sorting them out, working through their problem with them, and just defer it to the MDT as we'll wait for the MDT outcome. And I find it quite sad sometimes to open a patient set of notes and find a consultant has seen a patient in an outpatient consultation, and the plan from that consultation is MDT review. And I think that's a shame because we are clinicians, we are making decisions with our patients, and the MDT is there to support that, not to replace it. So just to summarise, and interestingly, there's some resonance here with what NHS England are proposing, and I hope what that reflects is that there is some listening to what's coming from the ground up. And I think what I've heard most from colleagues is we'd rather see a smaller volume of cases discussed in the MDT. And clearly this should be limited to those complex cases where there isn't an established, obvious evidence base. Particularly those where there's multimodality, multidisciplinary treatments required, chemotherapy, radiotherapy, and surgery. And we must have effective chairmanship to prioritise and streamline these cases, protocolise. But a caveat to that is the MDT chairman has got to have the time available to be able to do that properly. And the final plea, I guess, is to us all, is to try to remember the culture before the MDT, that really the doctor-patient relationship is paramount, and it's for us to own those decisions and share them with the patients, but be supported by the MDT, not to constantly defer it to the MDT. Thank you for listening, and I hope that some of you are suitably incensed to contribute to the discussion later.
Thanks very much, Jo. And Billy, if I could ask you to give your presentation, please.
Yeah, thanks, Ken. It was about 37 years ago that you and I were romping around being opinionated in a London medical school, and 37 years later we're back doing the same thing. I'm very humbled that you've picked me out of a lowly district general hospital to give this opinion. I'm going to do things slightly different. What's going to happen is you're not going to see my lips move when I give this presentation. So I'm going to do this in a different way, and I'll tell you why. About 2 years ago, when I came off coronary artery bypass, my brain's never really sort of quite clicked in the same way since. So when I was preparing this talk, I was beginning to realise that my short-term memory wasn't going to work. So I was going to have to read from a script. So rather than do that, what I've done is I put my presentation onto a timeline. And as Ken very much asked me to do, it is a polemic. It is maybe a slightly extreme perspective on where I think we should go with the MDTs. So I've got a video to play. I think, could you please start my video?
This brief presentation is to give you a very individual perspective on what the future of the urological MDT might look like in the United Kingdom. I'm going to limit the talk to 3 specific areas. First, a future perspective from the patient's point of view. I'll then discuss the challenges, dynamics and follies of our attempts to make useful and honest group decisions. Finally, I'll introduce a new primacy for the MDT, notably making it a central conduit for the delivery of multi-professional education. Let us start with the patient. Consider the case of this 54-year-old man with locally advanced lymph node metastatic colon cancer who had been treated by surgery and adjuvant chemotherapy 8 years ago. During an inpatient admission to the coronary care unit, a chest X-ray had been performed. Subsequent radiological reporting had identified a lesion in the left lower lobe. In our organisation, this generated a Code 5 report to both the lung and colorectal MDTs. A Code 5 is a mechanism whereby abnormal imaging can be directed to the most appropriate clinician. In this case, out with the patient, both MDTs requested a PET MRI for the patient in question. The only thing was that the patient had his own philosophy on cancer care and did not attend for either of these duplicated investigations. What a waste of time and money. Actually, that patient was me, and so after 25 years of being party to MDT meetings, I became a true patient consumer too. So here's the thing. The patient must be truly pivotal to the structuring of any MDT. I know that this has been discussed already, but in simple resonance, this is what I think. First, all patients must always be seen in advance before they are ever included in any MDT discussion. With their clinician, they will agree what questions will be asked. Whatever the conclusions or disagreements that emerge from the MDT, then these will be formally shared with the patient. The sentiments here are nothing new. However, an agreed sequence of questions that must be formally answered will focus the conversation and make best use of the expertise that is to hand. I'm sure that is the simplest of the changes needed. So, turning now to the vexed concept of the group decision. A fundamental tenet of the MDT process is that a group decision is somehow better. There is a belief that wisdom emerges from a group, that idiosyncrasies of care are checked and quality standards maintained. In other words, that the crowd is wise. There is also an assumption that our decisions are founded on good knowledge. So, let's explore some of these ideas. In 1997, a tragedy occurred on Mount Everest. 22 experienced climbers, or experts you might say, were led to their deaths in a spectacular failure of group decision-making. The story is told by John Krakauer in his now famous account, Into Thin Air. In this tragic example, it was clear that the group was not wise. Wisdom did not emerge from this crowd. Since then, many studies have shown why in this, and many other groups, failings occur. But before I explain what these are, let us just consider another example from our own justice system. Here, experimental trials have been done with mock juries. The outcome measured is the likelihood of achieving the correct verdict. In these examples, it has been shown that, across the 12 jury members, at least 22 changes of opinion must occur within that group if a sound verdict is to be reached. In other words, a true debate with individuals changing their opinions based on the different perspectives of the evidence must be part of any group decision-making process. So, from both these examples, the problems that can be exposed by small groups of expert decision makers is made clear. The Urology MDT group is not too dissimilar. It generally comprises about 12 to 22 members, most of whom consider themselves to own some sort of expertise. Here is a summary of the problems that can be encountered with small groups of expert decision makers. These factors may be operant in the Urology MDT group. First, there is the problem of groupthink. The group members are all very similar and likely to hold the same well-intentioned views. Second, decision processes tend to follow a cascade. In other words, individual opinions are often expressed after the views of others are known. This can lead to a kind of mimicry in the group. Third, the inherent hierarchical structures of such groups minimize dissent. And finally, while debate may seem to occur, individual position changes are actually rarely encountered. In reality, we call these faux debates, where individual opinions do not budge. As Nietzsche said, bizarre decisions from individuals are rare, but from groups it is the rule. Many of you will recognise such factors as being operant in your own MDTs. Others may think that this is an unfair reflection of your practice, and, I agree, the execution of MDTs is highly variable. However, brilliant contemporary work by Ben Lamb and James Green, two of our very own academic urologists, have found clear evidence for all these shortcomings. Indeed, given that this is now so widely recognised, there has been a suggestion that the MDT is no longer used as a decision-making chamber, but that patients are simply directed towards pathways of care. On the surface, this may seem to be a reasonable compromise, but this too has limitations. First, we have to assume that we have good knowledge. In other words, that pathways are founded on a bedrock of solid knowledge. But I would challenge that too. I will illustrate my concerns with an example taken from Siddhartha Mukherjee's now classic History and Philosophy of Cancer Care. The Emperor of All Maladies is the biggest selling cancer book of all time. In it, he teases us to answer three insightful questions. First, what is cancer? Second, why does cancer kill? And third, why do we have MDTs? I posed these three questions to our group of 18 urology trainees in KSS. Arguably, these are some of the brightest future urologists and shapers of better cancer care. The results of this survey are illuminating for a number of reasons. Consider some of the answers given. First, for the question, what is cancer? Responses ranged from something created to scare people irrationally to the more thoughtful yet arcane. It is the abrogation of cellular division and programmed cell death such that there is a loss and then destruction of tissue architecture and integrity. This leads to organismal dysfunction, distress, and impoverished interaction with the life process. Clumsy perhaps, but actually fairly close to a standard definition provided by the NIH. Either way, when I considered the definitions thematically, 18 respondents provided at least 22 broad definitions. Similarly, for the question, why does cancer kill? I was able to identify 22 vague and often barely logical descriptions. Furthermore, several of the trainees could not but resist making remarks like, because they were unfortunate enough to have their cases discussed in an MDT. While such remarks may have been made in jest, they also serve to illustrate both our own intellectual frustrations and a general scepticism that has become imbued in our junior ranks. That said, I was much more heartened when we asked the question, why do we have MDTs? Almost to a person, most of the trainees said that they were great learning opportunities that were often unsurpassed in their working week. Being able to intuit both good and ill-considered cancer care with an exposure to expert real-time image interpretation was seen to be invaluable, and it is to this that I now turn. I hope I have been able to show that the MDT does not serve as a safe, consistent or valuable decision-making chamber, and that in my view this should no longer be a focus or measured outcome of the MDT process. Rather, this should become an opportunity to deliver multi-professional education. For Health Education England, multi-professional education, delivered in the workplace, is seen to be the most logical, cost-effective and valued mode of modern-day clinical learning. However, delivering high-quality educational products to the complexities of the workplace, where service tensions prevail, is one of the greatest challenges for clinical educators. And there is no doubt that good decision-making centres on good education. I have extensive experience of dealing with this pedagogical challenge. As the author of the National Catheter Education Project, we have developed a learning programme presented in story form that seeks to universalise the concepts of catheter care to a multi-professional group. This is a dynamic, ever-evolving course that is responsive to participant and patient feedback and has become a consensus product that is representative of good practice in the United Kingdom. It is called The Secret Life of Catheters and is also linked to a systems change agenda whereby improvements in care standards are directly linked to the uptake of teaching in the workplace. But believe me, trying to find ways to get this learning to our busy colleagues is notoriously difficult. How can we push our learning products into the clinical workspace? Well, herein lies an opportunity for the future MDT. If we accept that the MDT can never be a sound decision-making chamber, it could morph more usefully into being a formal educational platform of worth. So how would it work? Well, in simple outline, consider the eternal conversations that are now seemingly no longer challenged. What is the natural history of human prostate cancer and the doubtful benefits of investigation, surveillance and treatment? What are the huge expense of delivering chemotherapy to people dying from solid urological tumours? We all know that there are trials that shakily suggest a benefit, but are we in full awareness of what those benefits truly are? Then, consider the complexities of human comorbidity that constantly undermine our attempts to offer meaningful treatment. Yes, stratifications, algorithms, and developments in personalised medicine are emerging, but who really has a good grasp of these concepts? These are to mention just a few, but I'm sure they are all depressingly familiar with you all. They are repeatedly central to any typical MDT. But in truth, we just don't know the answers and are in the fog of uncertainty. Consider this as an opportunity. The MDT is a captive, multi-professional audience. We could develop short animated learning bites that, just like the National Catheter Education Programme, evolve through a dynamic self-learning model. Thus, an ever-updating teaching product, grown from a national consensus, would be constantly available. These learning clips could be pulled up, just as we do with imaging, in the MDT forum. When the bog-standard controversies arise, the education is on hand to temper and guide any subsequent debate. It would be a huge project that we would develop through our own urological community. It would require considerable funding from Health Education England and probably BAUS. But it would be an egalitarian product, a venture of meaning, and would make our MDTs truly worthwhile and fun. Well, that is my view. Thank you.
This guy never ceases to amaze me. That was an extraordinary talk, Billy. Thank you. And thank you to Joe and thank you to Hash. We've just got a couple of minutes for some questions, and they seem to have worked, so it's come up. I'm not sure who's going to win the World Cup was particularly valuable, whoever sent me that one. Is there any evidence, Hash, that MDTs have improved cancer survival in the UK in the 22 years of its running?
I think the short answer is there's no clear evidence on that, but I think any of us that think MDTs are not useful would be wrong. I think all of the reports and the consensus, and I don't think Joe deferred from that, is that an MDT working process does help in the majority of questions. But I do agree with Billy in that ultimately the decision must be made at the patient to clinician interface, and sometimes MDTs can be taken as doctrine when they shouldn't be. They are still guidance.
And I think Joe picked up on that, and it's something I'm keen on. Does that mean that you want the decision to be made before the MDT, and then you take the patient, that decision to be ratified or challenged?
Well, I think what I meant by it was that too often we simply see MDT review as the decision, and the patient is left then waiting for options, outcomes to be discussed, and isn't really participating in it. And I even see the worst possible, which is where a clinician will see the MDT outcome and then refer the case back to the MDT because they don't agree. I feel it's a process for having additional input of specialists and perhaps coordinating care, but I do feel quite strongly that the decision is still between patient and doctor.
Yeah, fine. Thank you very much.
And if I could just add, actually, I think that the end point or the goal of the MDT doesn't have to be survival. There are many other purposes and endpoints for an MDT beyond that.
Yeah, indeed.
Can I come back in on that one as well, please, Ken? Just to say, I think that the patients who really do badly out of the MDTs are those who have particularly complex, difficult cancers, often not curative, and they are often the ones that are kicked to the end of the MDT list whilst we're discussing all of the so-called curative cases first. So I would agree with Bill on that.
Well, that's been a fantastic discussion and session. I'm really grateful to the speakers. As you know, it takes a lot of work to put these together. So thanks very much, you guys, and thanks for attending and listening.